Next, we're going to call up two speakers from representing the National Academy of Science and Engineering and Medicine, a standing committee on primary care. But first, let me do a little background on why these two individuals are with us here today. So in 2021, NASEM released a landmark study on improving high-quality primary care in the United States. That study made a number of recommendations, 5 pillar recommendations about actions that governments, private sectors, and organizations should take to improve the state of primary care in the United States. One of the recommendations that report made was the creation of an oversight body, or a body that would work with outside entities, federal agencies, and interested parties to advance or continue to advance the recommendations of the report published in 2021. So today we're fortunate to have the lead staff, Marc Meisnere, and one of the co-chairs, Lauren Hughes, with us today to talk about the work they are leading and the work of the Standing Committee and how we can all learn from and work with to advance the work they're doing. So Marc Meisnere, I would like to call you up, and thank you for being with us today.
Thanks, Sean. Hello, everyone. It's a pleasure to be here today. I'm Marc Meisnere. I'm the Senior Program Officer at the National Academies of Sciences, Engineering and Medicine in the Health and Medicine Division. And as Sean said, the Project Director on the National Academies Standing Committee on Primary Care. I'm here with Lauren Hughes, who is an Associate Professor of Family Medicine and State Policy Director of the Farley Health Policy Center at the University of Colorado and co-chair of the Standing Committee. And we are very happy to be here to talk about the work of the committee and the work that led up to the committee's formation and a bit about where the committee will go from here. And Sean, I want to thank you and the Academy of Family Physicians for inviting us to be here and also being among the coalition of sponsors that is supporting the Standing Committee's work. So just a bit about the National Academies. Very quick orientation. The National Academies of Sciences, Engineering, and Medicine. There are 3 academies: the National Academy of Science, the National Academy of Engineering, and the National Academy of Medicine. Together, we're known as the National Academies of Sciences, Engineering, and Medicine. Some people refer to us as NASEM, or the National Academies for short. So we were founded in 1860. President Lincoln established the National Academy of Science to advise the nation on pressing issues related to science. So we have quite a long history. In the 60s and 70s, the National Academy of Engineering and the Institute of Medicine were established to work on complex issues related to those topics. We're in a unique position within public health policy to provide independent, objective analysis and advice to our nation and abroad. It's important to note that NASEM is not a special interest group or a lobbying organization. Our work is driven by evidence and expert opinion of the volunteers that serve on our committees. In 2015, the National Academies undertook a huge reorganization. And in March of 2016, the program division of the Institute of Medicine, which many of you may know, or the IOM, became the Health and Medicine Division of the National Academies of Sciences, Engineering, and Medicine. So today we build on the heritage of the IOM's work in medicine while emphasizing increased focus on a wider range of health matters. So HMD, the Health and Medicine Division, is now fully integrated in the broader work of the National Academies, facilitating more collaborative and interdisciplinary approaches to the most pressing challenges facing the nation and the world. The integration strengthens our work by leveraging the expertise of both volunteers and staff across the organization. All reports of the National Academies are branded as the National Academies of Sciences, Engineering, and Medicine, while reports published before the reorganization retain their citations as the Institute of Medicine. NAM, which some of you also may know, the National Academy of Medicine, is the membership side of the organization and coordinates membership activities and other efforts, such as action, collaboratives, and special publications that are not subject to the same FACA rules that the consensus reports are. Consensus reports are published by the Health and Medicine Division of NASEM, including the 2021 Implementing High Quality Primary Care Report. Our credibility is gained through our policies and procedures, which are extensive. For example, we keep at arm's length from our sponsors through our processes. We devise our statements of task, which guide our work, with sponsor input, yet the day-to-day sponsors are not involved in that process. Before a committee is approved, they go through a rigorous bias and conflict of interest procedure. We have open meetings to gather public and stakeholder input. And we also hold closed meetings to conduct confidential deliberations and to protect the conversations of the committee. Our publications undergo a rigorous review process before they are released and delivered in final form to sponsors and the public. So as I mentioned FACA before, that's the Federal Advisory Committee Act. So standing committee activities are subject to FACA, and Section 15 of FACA establishes a number of requirements for studies conducted by the National Academies. In short, federal agencies can use the advice or recommendations of a National Academy's study only if it meets the FACA requirements. These requirements are related to conflict of interest vetting, and other transparency policies related to public notice of our meetings and public access to the information we receive from outside of the committee. So today, Lauren and I are going to talk a bit about the Implementing High Quality Primary Care report, which was released in 2021, a bit about its impact and how it led to where we are today with the Standing Committee on Primary Care, which Sean alluded to a bit in his introduction. So you can see the report on the screen. It was released in May of 2021. It's likely familiar to some of you. The federal government has cited this report repeatedly as a roadmap for its primary care policy. And as we get into it a bit, it has catalyzed real change and continues to inform the field. So also, as Sean mentioned, there were 5 overarching objectives in the report to achieve high-quality primary care. It included an implementation plan with specific recommendations that fell under each of these objectives. There's obviously still a long way to go in implementing this fully, but we've seen some movement, particularly around payment recommendations. So the first objective, pay for primary care teams to care for people, not doctors to deliver services. There's been a good deal of federal action on this recommendation. Perhaps most notably, CMMI has launched a number of demonstrations that align well with the report's recommendation, namely the ACO Flex demonstration, the AHEAD demonstration, and the Making Care Primary demonstration. ACO Flex will test how prospective payments and increased funding for primary care and accountable care organizations impact health outcomes, quality, and cost of care. The flexible payment design intends to empower participating ACOs and their primary care providers to use more innovative, team-based, person-centered, and proactive approaches to care. It aims to grow participation in ACOs and shared savings models. The model will launch in 2025. AHEAD focuses on leveraging primary care as a lead strategy for improving health equity. It builds on successful models in Vermont, Maryland, and Pennsylvania, and it holds states accountable for population health and equity. It adjusts payment for social risk, and it is an all-payer model with aligned financing for 11 and a half years. Making Care Primary is similar to the AHEAD model, but focuses on small, rural, underserved practices. The second objective, ensuring that high-quality primary care is available to every individual and family and every community, has seen some movement, but not quite as much as the payment objective. For example, the committee recommended that HRSA's Health Center program be expanded, and we have seen a bit of that, and there's been more sites for health centers around the country. However, funding has been mostly unchanged, and actually, if you adjust for inflation, it has slightly decreased. For the third objective, train primary care teams where people live and work. Again, we've seen some movement in an increase in rural training opportunities for primary care. However, there have been few grants for interdisciplinary training, which is one thing that the committee recommended. And there's been little movement regarding other training recommendations in the report. For the fourth objective, design information technology that serves the patient, family, and interprofessional care teams, there has not, unfortunately, been any clear movement on the recommendations from the report. The fifth objective, ensuring that high-quality primary care is implemented in the United States, there has been some action on the accountability recommendations. The report recommended that there be a primary care scorecard to track progress across the 5 objectives outlined in the report. Milbank Memorial Fund and the Graham Center has released 2 scorecards in 2023 and 1 in 2024, and I believe Yalda Jabalpur will be presenting on one of them on the 2024 scorecard later today. Massachusetts has also released a scorecard, and the Office of the Assistant Secretary of Health is working on a dashboard for their own tracking purposes. And also, as Sean alluded to, the committee also recommended that HHS establish a Secretary's Council on Primary Care to enable the vision of primary care captured in the committee's definition. So in response to this recommendation, HHS's Office of the Assistant Secretary of Health launched its initiative to strengthen primary health care in 2021 to coordinate primary care activities across the federal government. The NASEM report also recommended that this council should be informed through regular guidance and recommendations provided by a primary care advisory committee. So the Standing Committee on Primary Care fulfills the primary care advisory committee function that the 2021 report recommended. So up on the screen is an outline of the statement of task of the Standing Committee on Primary Care. Every NASEM activity is guided by a statement of task, and it must abide to it throughout its work. So the statement of task language was agreed upon by the sponsors of the Standing Committee, and I'll get to those sponsors in a bit. And Standing Committee reports can include recommendations and go through a rigorous review process before publication. So here is our Standing Committee. We have 20 members. I'm not going to read their names, but you can see them all on the screen. We have 17 clinicians, 12 of whom are practicing, several with current or recent experience in FQHCs, and they cover a wide array of expertise, including family medicine, general internal medicine, pediatrics, nursing, social work, experts in rural health and community-based care, federal and state programs, mental and behavioral health, health IT, workforce development, and more. The committee launched in late 2023. We are funded for 3 years total and are most of the way through that first year. So here are our sponsors. We could not do any of the work of the Standing Committee without the generous support of them. And as you can see, we have a broad coalition of support. It's important to note that, as I mentioned before, we do maintain we do operate at arm's length from these sponsors. They're not involved in the day-to-day operations of the Standing Committee. They are welcome to submit information to me, which I can share with the Standing Committee. And we encourage them to participate in all of our public activities, and many of the sponsors did participate in our open meeting that we had earlier this week that Lauren will discuss in just a bit. So how the Standing Committee does its work. We have 2 main work streams, public meetings and publications, focused on advising federal actions. The first public meeting was in November of 2023, during which the Standing Committee heard from sponsors about their priorities. And the second public meeting was on Monday and Tuesday of this week, during which we heard from federal leaders from CMS, from both Medicare and Medicaid, CMMI and HRSA, as well as many other experts around primary care payment, access, and workforce. We have 2 more public meetings this year in September and November. And the committee has also met in closed session many times with the full committee or work groups within the committee. We've not released any publications, but the committee is interested in doing so. We are currently digesting the material we heard this week at the public meeting, and we anticipate that some publications will emerge out of those discussions. So we continue to have conversations through staff, through me mostly, with federal leaders to understand their priorities and find out areas where the Standing Committee can be of service. And I'm now going to pass the mic to Lauren, who's going to talk us through some of what we learned at our public meeting this week, and where we're going from here.
Great, thank you very much, Marc. And as Marc alluded to earlier, my name is Lauren Hughes. I am a family physician and the State Policy Director for the Farley Health Policy Center at the University of Colorado. And I am honored to serve as one of the co-chairs for the Standing Committee on Primary Care, along with my colleague, Dr. Mary Wakefield. So if Marc and I look a little tired, it is because we just emerged from 2 very robust days of discussion with our first in-person public meeting of the Standing Committee on Primary Care. And this morning I will share at a very high level some key takeaways that span both days, as well as needs that were collectively identified by all speakers that really represent opportunities to strengthen the foundation of our healthcare system. Please know that what I'm sharing today are not official recommendations from the Standing Committee on Primary Care or from the National Academies at this point in time. So I want to walk you through some of the highlights of our agenda for day 1 and followed by day 2. Day 1 focused on primary care financing and payment. We had 5 very robust conversations, panel sessions on the first day, which was this past Monday. We heard from our colleagues from CMS and from the Innovation Center about lessons learned from the different primary care models that they have designed and implemented, and what may be implications for future models. We then had a very in-depth discussion on valuation for primary care. What does that process look like currently, and what are opportunities to improve or enhance that process moving forward? We then listened to frontline perspectives on primary care infrastructure. What is needed to support interprofessional teams on the ground to deliver high-quality primary care services? And of course, that's intimately linked to payment for those services. We had a panel that focused on state-level innovations, and we heard from experts from Virginia, North Carolina, and California about what they are doing in primary care and what are lessons learned or implications for our federal colleagues to help facilitate those state-level innovations. And lastly, for the first day, we had a conversation that addressed federal and state primary care access standards enforcement with a focus and emphasis on Medicaid. Day 2 was dedicated to the primary care workforce, and we divided our 3 panels into 3 areas of focus: long-term, medium-term, and short-term solutions to strengthen the primary care workforce. From a long-term solutions standpoint, we really kind of dove into graduate medical education. What are some needs to enhance that? We also had a conversation that focused on the importance of community-based training and how can we improve or enhance access to those opportunities. The medium-term solutions for growth panel relative to workforce really addressed the importance of the interdisciplinary team to address needs and to enhance access for our patients, families, and communities. This panel featured a nurse practitioner, a psychologist, a pharmacist, and an individual representing or studying kind of the needs of community health workers and their roles on primary care teams. So very robust discussion in that panel. And then our short-term solutions panel focused on the increasing role and opportunities with technology and new entrants into the primary care space as potential opportunities for increasing access to needed primary care services in the short term. So key takeaways from the first day: financing and payment. These were, as Marc and I processed pretty rapidly, the robust conversation from the past 2 days, these would be the key takeaways that I would offer to you relative to financing and payment. The first, and this was a pretty clear signal across the various panels, that primary care is nonpartisan. We also heard from a variety of our federal colleagues that they are using the 2021 NASEM report that Marc discussed. It is really being used as a playbook by our federal agencies to strengthen primary care. We absolutely heard a great deal about the need for enhancing payment, the need for the amount of primary care payment to be increased, both at the practice level and to think about what is needed to enhance infrastructure at the state level and to make those needed investments. The panel acknowledged that given the substantial percentage of payment that is still tied to fee-for-service, that we cannot ignore the fee schedule moving forward. And for alternative payment models, ample perspective hybrid payments are essential. And the last takeaway on this slide focuses on new payment and delivery models for primary care. The speakers emphasize the importance of sustainable and permanent pathways for these primary care innovative models and or features of them, so not necessarily an all or none. And also there was a suggestion that we need to have a replication strategy for other states that may not be in that initial round of participation for those innovative models, and what might that look like. Additional takeaways from day one relative to financing and payment. The first takeaway may inherently be obvious in the way that it's stated here, but there was a concentrated focus on the importance of aligning multiple payers for these different models, and that it's very critical to engage those payers in the design of multi-payer models. It was also emphasized that employers and purchasers are incredibly valuable partners and need to be brought to the table as well. A great deal of focus on patients as partners, not just in their own day-to-day care, but how do we bring patients to the table to help us design and implement models. One of our speakers suggested that it's important to think about how to make it easy for patients to voluntarily align with value-based models and to reward them when they do so, such as waiving copays for primary care services as an example. There was also a great deal of discussion across both days, but in particularly the first day, on the challenges with differential investment from the federal perspective in some of our states versus others when it comes to building over time a primary care infrastructure. And so the question was raised about how to make sure that we're kind of getting everybody on the bus relative to the states that may not historically have received federal investment in primary care infrastructure. And our Medicaid Access Standards panel really drove home the importance of taking a multi-pronged approach to enforcing these access standards. You can't just look at one lever. Important to take a multimodal approach to these different levers. And you see some examples here, including simultaneously addressing wait times and network adequacy standards, establishing accountability measures, designing incentives in a thoughtful way, and examining services that are covered by state plans. So what are some identified needs that came through from the first day? Again, focus on financing and payment. Again, these needs, from my vantage point, certainly represent opportunities for action for those of us that care about primary care from a variety of different perspectives to move the needle forward. From our federal colleagues, we heard this question surfaced a couple of times. What do primary care providers and practices, especially small and rural practices, need to join value-based models? A lot of that discussion focused on differential experiences with risk and perhaps some reticence to take on downside risk, particularly for our smaller and more rural primary care practices around the country. But this was certainly a very honest and earnest question that was raised during day one. Medicare Advantage was a popular topic now that it represents half of the program. And a call for data on all fronts was made in a number of different ways. This is not an exhaustive list of the types of data or analysis that may be needed, but this is represents a good start. So data and evidence around cost, quality, and access for beneficiaries, marketing practices, delays in payment through Medicare Advantage, as well as denials that beneficiaries may experience relative to needed services. On the state level sort of innovation panel, it was discussed at length that more and more states are getting into the business of primary care spend, trying to calculate it and or setting targets and benchmarks that the states wish to reach relative to this level of investment. And there were a number of asks for a common definition that would be very helpful and allow us to have more interpretable comparisons across states that are engaged in the primary care spend space. 3 other needs identified on day 1: metrics, metrics, metrics. Can we align them already across different payers? Number 2, focused on the evaluation process for primary care. More work is needed to better understand the limitations of the current approach, as well as to identify the time and effort required for interprofessional teams to deliver high-quality advanced primary care. One of my colleagues in the standing committee spoke to her personal experience from practicing for a number of years in a federally qualified health center environment, and talked about the things that many of us know, that when you want to deliver high quality primary care, all of these extra sort of non-billable services and time and investment spent to help patients get what it is that they need, there is very much a desire to understand the time and effort that goes into those things that aren't currently accounted for. The question remains, what are the principles and the processes for alternative inputs that would still meet the statutory requirements for evaluation of primary care services? And last but not least, kind of returning to scaling and spreading of care models as well as new codes. The committee had a robust discussion around what is needed to, whether it's parts of or the entire models for our CMMI demonstrations, to scale and spread those. What are the opportunities that are before us to capitalize on learnings from models within the VA and from the various payers that are engaged in innovation spaces? What can we learn and scale and spread from those stakeholders as well? And then lastly, particularly with regard to the new G codes for health-related social needs services, many calls for a need for education around these. So there's a lot of need to learn more about what these are and how to apply them. So moving on to day 2, key takeaways that surface in the conversation relative to workforce. Mentioned a number of times throughout this day, the patient is the most underutilized member of the primary care team. They are the experts in their own lived experiences, and so how do we pull them in as a member of that team relative to their own care, and again, to the design and implementation of primary care models and clinical workflows in their local clinical settings. The second takeaway, primary care GME needs to be sustainable, socially accountable, and increasingly community-based to reflect where it is that a majority of Americans receive primary care services. The third bullet, the types of professionals on a primary care team should vary depending on patient and population health needs and the local context. It was a lot of discussion around the importance or the need for interprofessional teams to have substantial upfront investment to better support hiring of particular types of professionals, for example, community health workers or peer support specialists, their training as a team, as a cohesive unit, and then ongoing quality improvement. Relative to interprofessional teams, there were 2 other what I would call sort of sub-takeaways that were very much emphasized throughout the second day, which was yesterday. The first is that primary care, if we want to deliver high-quality primary care services, it requires a team, period. End of story. When we think about increasing health-related social needs, we think about increasing needs for reporting, increased technologies that are available to us. Primary care has become much more heterogeneous and much more complex and requires a team to deliver those high-quality services. There was also a call for stating, we know that teams deliver high-quality care. We do not need to invest a lot more research into the fact that teams do deliver that high quality care. Let's figure out how to support them financially, how to help train them, et cetera. That's where we need to emphasize or to focus our efforts moving forward. And the last takeaway from workforce, emerging technologies, payer and purchaser innovations, and new sites of care are here to stay. So how do we more efficiently work together to connect the dots between those technologies, these innovations, these new entrants, new sites of care, to the principles of high quality primary care as outlined in the 2021 NASEM report? So reflections and next steps. So again, what I've shared with you is our first pass at sort of sorting through all the valuable information out of the last 2 days from our public standing committee meeting. This really is, what I've shared today represents opportunities for us to respond to these needs from our different perspectives. As the National Academies, and Marc alluded to this earlier, we are not a professional association, an advocacy organization, or a lobbying firm. That said, we will continue in our lane and in our role to identify, synthesize, and translate data and evidence to respond to questions our federal agencies have about various aspects of primary care policy. The webcast and presentations from our public meeting the last 2 days will be available on the event webpage within 1 week. I strongly encourage you to visit our website and to take a listen to the robust conversations. And then please stay tuned. Information will be posted on our standing committee website for information about our next 2 public meetings. They will be virtual, held in September and November of this year. So for those of you that would like to support this standing committee, we would very much welcome your input and your support, and these are some ways to do this. First, to attend public meetings. And again, many thanks to several of you that are here today that participated the last couple of days. Through Marc, who's a senior program officer and staff lead for the standing committee, please send us information, literature, and data to consider, particularly if for some of the opportunities or identified needs that I talked about today, if there's information that you would like to share with us, we are all ears, and please make sure to direct that to Marc. We'd also welcome your suggestions on topics for future meetings and publications. We also would appreciate your recommendations on clinical or other experts to participate in standing committee activities. And last but not least, on certain topics, particularly as we get into the weeds and understand what evidence does and does not exist, if we reach out to you or your colleagues with specific questions, we would greatly appreciate your engagement on helping us identify and track down that evidence. And last but not least, I want to make sure to share our website here, where you will find more information about the Standing Committee. Again, bios for committee members, information on upcoming meetings, as well as within a week. Again, the recording from our webcast from the last 2 days in our public standing meeting. And with that, I will bring us to a close. Appreciate very much the opportunity for Marc and for me to talk about the Standing Committee on Primary Care.